Hi everyone, welcome back to UWorld's Next Gen NCLEX review. My name is Samantha. I am a nurse here at UWorld and I'm so excited to see you all today. Thank you so much for tuning in. So today we know a lot of you guys are graduating in that crunch time, starting to prepare for the NCLEX. So we're going to try and hit some big, heavily requested topics for you guys. And today that is going to be pediatric. So we're going to talk about some common pediatric conditions, including RSV, strep throat, and head lice. So really common things that you're going to see in the pediatric population. Let us know if anyone here is interested in going into pediatric nursing. Maybe you're in a clinical right now that puts you into a pediatric hospital. But regardless of where you are, we can all take a lot from this and we can all apply it to our NCLEX. You will be tested on OB and PEDS, so even if you don't want to go into pediatrics, you will need to know some of this information. So housekeeping things before we get started, we do take into account the things that you guys want to see, so keep letting us know the topics you want to see us present on. There will be questions throughout today's video, as well as our NCLEX style questions at the end, so make sure to stay tuned in because you don't want to miss those. And a reminder to drop your answers to today's questions into the chat. We have the wonderful nurse Jasmine moderating. Let her know any comments you have, any questions you have, and of course those answers. Also, if you haven't already, follow us at UWorld Nursing on whatever your preferred social channel is, so you don't miss any of these live lecture sessions or our question drills to come. Alrighty, so this live will be on demand on our social channels when we are done. So if you miss something, if I go too fast, you're always able to drop back in on it. I find our YouTube channel as the easiest one to search. And lastly, keep those comments coming. Let's get the chat started by letting us know where everyone is joining from, who is tuning in from the good old USA, who is joining us internationally. Regardless of where you're coming from, we are so happy to have you here. Alrighty, so quickly to hit on the agenda, we're going to cover RSV first, move into strep throat, and then top it all off with head lice. We'll have questions scattered throughout, so make sure you pay attention because these are really great little knowledge checks to kind of bookmark our way as we go. So we're going to start out with bronchiolitis, or RSV, which is short for respiratory syncytial virus, but we'll just call it RSV for short. So this is an extremely common viral infection. It affects so many different kiddos during cold and flu season. If you've ever been into a pediatric ER in the winter months, you can see just how widespread RSV is. So what happens with RSV? First of all, RSV is a highly communicable disease, meaning it's very catchy. It spreads really quickly. It's spread by respiratory droplets and by direct contact, like child to child, or indirect contact, like a child to a toy. Maybe they put down that toy and then another child picks it up. They can then contract RSV. So when we think lots of different things. So in our lungs, we have small tubes called bronchioles where air passes. Now, bronchioles are going to be the smallest branches of our airway. In RSV, the bronchioles, they get inflamed and we have lots of mucus secretions that increase. Therefore, these two things in tandem make it harder for air to pass through, which is going to make it harder and harder for this child to breathe. So big picture with RSV, it's in the name. It's respiratory. So big picture, it indicates respiratory distress. And it's viral, so we know that our treatment is likely going to be supportive. So before we get into respiratory or risk factors, a quick note that RSV is going to be diagnosed via that nasopharyngeal swab, same as those original COVID tests that go all the way up through the nostril, through the nares. This is very unpleasant even for adults, so you can also imagine that this is even trickier for those pediatric clients. All right, so our risk factors. RSV is a virus that affects our youngest populations, but it can also affect our oldest populations. So think of those infants that are 6 months and younger, as well as our elderly clients that are at a high risk for contracting RSV and even higher risk for contracting complications from that RSV. So RSV can also affect anyone who's immunocompromised, so clients who are undergoing chemotherapy or maybe on immunosuppressant medications. Also think about our clients that already have weakened lungs, those underlying pulmonary conditions, maybe an asthma or a CF, a cystic fibrosis. Here the lungs are already compromised, so when we introduce worsening inflammation and increased secretions, this is going to lead to some really big picture complications for these clients. Our last risk factor are kids that are exposed to secondhand smoke. So they're at high risk for complications from RSV. When these children and their immature lungs are around that smoke, the inhalation of the smoke causes inflammation of the lung. It's similar to what we said about our clients who have pre-existing lung conditions. When RSV enters the body and causes worsening inflammation on top of the original inflammation from that secondhand smoke, these pediatric clients will be more likely to suffer from the complications of RSV. Alrighty, so moving along to clinical features. Now the severity of these are going to greatly differ. The onset may vary, but in RSV, symptoms typically peak around day 5, which usually those days 3 to days 5 being the worst days. Symptoms can be as mild as just a runny nose, cough, sneezing, fever, that sore throat, but over the time these symptoms can worsen, and we're going to start to worry about the A and the B of our ABCs. Remember, ABCs are airway, breathing, circulation. We're really concerned about the A and the B, the airway and the breathing. We can differentiate RSV from like a common cold because we typically see symptoms from a cold only in our head, but with RSV, those symptoms really present themselves in the lungs. That's where they start out. That's what's most affected. So before we pull up an image for you guys, I want you guys to tell me, what do you think respiratory distress looks like in a pediatric client? So go ahead and drop those answers in the chat. What do you think respiratory distress is going to present as in pediatric clients? What do you think we're going to witness in them? What are they going to be doing to compensate? How are we going to know that they are in respiratory distress? I see some great answers. Thanks for participating. Alrighty, and I see nasal flaring, retractions, use of accessory muscles. You guys are spot on, way to go. So let's hop to that labored breathing image. This is a great virtual or visual aid, that just kind of like drives home some of these key teaching points. Again, any of these visual references we include on our slides, you all are free to screenshot, take a picture, take it with you. We want you guys to be able to use this for your future studies. So when we look at RSV via a respiratory assessment, it's going to look a lot like this image of labored breathing that you see. So we're going to see signs of respiratory distress, signs of hypoxia. Starting out with that respiratory distress in a pediatric client, this is going to look like those adventitious lung sounds. So we're going to see wheezes, we're going to see some crackles, or hear, so wheezes happen when air has a narrowed path to travel. It sounds almost like a whistle. And crackles will happen due to that fluid. So it's kind of like bubbles popping. I always think of Rice Krispie treats that snap, crackle, pop. These sounds are due to inflammation of the airway, which is going to cause that wheezing, and those increased secretions that we talked about are what cause the crackles. So we're also going to see the use of accessory muscles, and I see Kathy Kate G got that one correct. Way to go. So essentially the body is engaging muscles that aren't typically used in the process of breathing to be able to help our muscles out to move more air through the lungs because this client is struggling. We may hear sounds like grunting, especially in our youngest clients, like our little infants, and we may also notice retraction. So especially if you look at the ribs, at the neck, the ribs would be called intercostal retractions. Below the ribs at the abdomen would be subcostal retraction, and at that neck, kind of where it meets the shoulder blade, is going to be, or the collarbone, suprasternal retraction. So we will see retractions. These clients can also have nasal flaring, again, the increase in the diameter of those nares. They'll have tachypnea or an increased respiratory rate, and of course, hypoxia. So when we take those vital signs, we may see O2 sats less than 90%. So now that we know all of these really scary things that can happen with labored breathing in a pediatric client, what are we as nurses going to be doing to help? What are our nursing interventions? So in this case, we're mostly going to focus on the interventions for a moderate or severe client. This is the client that's most likely to be admitted into a hospital or a clinical setting. So first things first, we want to prevent the spread of infection. So we'll need to enact those droplet contact precautions. So tell me in the chat, what are you going to do for droplet contact precautions? What are some of our contact precautions here for droplets? Let us know. Someone says good morning from China. Good morning. Thank you for joining us. Alrighty. So let us know, what are our contact precautions here? It's for droplets, so what are we going to need to do? Alrighty. Now it's droplets, so we definitely have to think about what that entails. That's not airborne, so we don't need that N95. Alrighty, I see some great answers here. So what we're gonna do for contact droplet precautions are gown, gloves, mask. So we don't need that N95. RSV is droplet, so think like a sneeze, big droplets in the air versus airborne, which is just breathing or talking. So we don't need that N95. Gown, gloves, and mask will be sufficient. So now that we're dressed and ready to care for this client, we wanna focus on supportive care. So this is gonna include things like administering IV fluids to keep the client hydrated, to help thin out those secretions, which makes them easier to expectorate or to cough up. We're also going to monitor oxygen, so we want to keep them over 90%. We might want to apply like a warm humidified oxygen to help further break up the secretions, open or relax that airway. These clients also have a proclivity to have really, really high fevers, so we want to give an age-appropriate antipyretic like a Tylenol or an acetaminophen. We do not give aspirin to pediatric clients with viral illnesses. Does anyone here know why? Why would we not give aspirin to a pediatric client with a viral illness? What are we worried about? And you guys, per usual, are spot on. Way to go. We're worried about that Ray's syndrome. So this is something that's associated with taking aspirin while sick with a viral illness that's common in our pediatric clients. We would not give an aspirin. We would give a Tylenol or an acetaminophen. So great job, you guys. You absolutely nailed that one. We also want to position these clients in a way that promotes airway clearance. So for pediatric clients, think about 30 to 40 degrees elevated with that neck slightly extended. This is especially important for babies. We don't want them smushed up with that neck kind of pushed into itself. We want the neck extended so their airway is nice and open. A lot of these infants can't fully control their head yet. Those heads are really heavy and the necks aren't quite strong enough. So for our infant RSV clients, make sure we keep that neck extended, have a nice open straight airway. Alrighty, we're also going to want to make sure we do frequent suctioning. So chances are a pediatric client, a kid is not going to like this. Now would be a really great time to use some of that age-appropriate communication. So for little infant clients, we may swaddle them so their hands don't get in the way. And for toddler clients, we want to explain to them what suctioning is, why we're doing it, let them look and maybe touch the equipment or a separate non-sterile equipment before we use the sterile ones. And these clients are going to need suctioning because they're not fully able to clear their airways on their own. They have younger, more immature lungs that aren't quite as strong as adult ones. So suctioning is a really important part of care here, but it's something that they may push back against. We also want to make sure we monitor I's and O's, make sure our client is not getting dehydrated and worsening their situation. Again, they're likely to have a pretty high fever, which means a lot of time they're not going to have as big of an appetite, they won't be eating and drinking as much, and they have the ability to get really dehydrated from this. So monitoring our I's and O's in the littlest infants, this may look like weighing and counting diapers. We also want to monitor for activity level and look for signs of decompensation. So kids are pretty resilient, but when enough is enough with some of these infections, we kind of see them cease activity, really become listless, and these are signs of pediatric decompensation. Lastly, we also want to monitor for signs of secondary infection. So things like pneumonia, acute otitis media, or ear infections, they love those increased secretions. It's like a breeding ground for different bacteria. So we can see secondary opportunistic infections arise from the increased secretion and the inflammation that we see in RSV. Alrighty, great job, you guys. Y'all did so well on that. We're now going to move into strep. So strep throat, we're with a viral infection. We talked about RSV. Now we're moving into a bacterial infection with strep. So this is the bacterial infection of the throat, another super common pediatric condition. If anyone here is going into peds, you will definitely see strep throat. So it's caused by the Streptococcus pyogenes, which is a group A beta hemolytic Streptococcus bacteria. It's diagnosed with a throat culture or a rapid strep antigen detection test. We'll always want to perform the diagnostic test for strep throat, but it has several key distinct symptoms that's going to key you into the need to perform the test. So that leads us right into our clinical features. So what does strep look like? These clients are going to have the abrupt onset of a sore throat. This may look like redness in the back of the throat. They can have swollen tonsils with an exudate, palate petechiae, so those pinpoint red spots on the palate. They can have fever. We can even see interior cervical lymphadenopathy. I always say that wrong. And a big pro tip for kids here, sometimes kids will have atypical symptoms. They'll present in a different way than maybe an adult counterpart would. Sometimes they originally present with like an upset stomach from that bacteria making its way into the stomach and the GI tract. So in that case, we can see them present with the GI symptoms, and some of these more respiratory, upper respiratory symptoms come on a little bit later. All right, so we're going to take a detour from clinical features and talk about some of the complications of untreated strep throat that are really unique to strep throat because of this bacteria. So these are some common things that can be caused by strep throat that goes untreated, maybe unnoticed, and it can actually complicate, and we can see some really pretty dangerous things here. So we're going to jump to a peritonsillar abscess image. So this is our first up complication that we can see from untreated strep throat. It simply means an abscess on the tonsil. I'm sure you all figured that out. These are an emergency, however, because they do have the potential to obstruct the airway. These are going to present with fever and chills. They can come on with some really, really terrible pain, bad enough for a client to not want to swallow, which means they won't really be eating a lot and they won't want to drink a lot of fluid. A lot of times they may even present with a muffled voice from the swelling of that tonsil that can deviate the uvula. Our next complication is something called rheumatic fever, which takes about 2 to 3 weeks to surface post-strep. Again, this looks like untreated strep throat, that the bacteria makes its way somewhere else. It happens when antibodies against strep bacteria develop and they start attacking the healthy tissues of our heart, our joints, and our kidneys. So what we worry about most is something called pericarditis, which is the inflammation around the heart. We can see things like joint pain from this. We can even see chorea, which is the involuntary muscle movements. Our next potential complication is something called acute post-streptococcal glomerulonephritis. So this strep bacteria can make its way all the way down into our kidneys and wreak havoc. Again, untreated strep throat essentially is the invasion of strep bacteria down into the kidney. So it's going to manifest as like peripheral edema from impaired kidney function. Same idea as an adult with an AKI or an acute kidney injury. We can see hypertension and Coca-Cola colored urine. So that really dark cola colored urine, which is a color variation of hematuria, meaning blood in the urine. So instead of like frank red blood, it's going to be dark blood. But again, that cola colored urine is one of our key hallmark signs of acute post-streptococcal glomerulonephritis. Last but not least is something called scarlet fever. So this is going to present as like a sandpaper-like rash and a strawberry tongue. We can see those beefy red papules that look like a strawberry. That's where strawberry tongue comes from. And again, all of these are from untreated strep throat. Scarlet fever was really, really dangerous in the olden times. I don't know if any of you guys watched Little House on the Prairie, but Mary gets this. That's always what I think about when I see scarlet fever. But again, a lot of really dangerous complications that can come from untreated strep throat. So especially for our pediatric clients, it's so, so important to get them prompt health care to make sure they take the antibiotics, they finish the full course of antibiotics, and none of these complications arise. All right, so final part of strep throat are going to be our nursing interventions. So typical medications for strep throat, which we know is a bacterial infection, are going to be antibiotics. No surprise there. I want you guys to go ahead and let us know what you think are some medications, some antibiotics used to treat strep throat. So drop that in the chat. What is a common antibiotic we see treat strep throat? Let us know. Keep those chats coming. Alrighty, you guys are doing so well today, and I see a couple of chats coming in. Thank you so much. But for clients without penicillin allergy, we typically give something in the penicillin family. So I see penicillin, I see amoxicillin. You guys are spot on. So for a client with a penicillin allergy, we may give something else, but penicillin is going to be one of our most common medications to treat strep throat, or something in the penicillin class of medication. So we also need to give supportive medications that help reduce fever, like an antipyretic or an analgesic to help with the pain. We're also going to help teach the client about the need to consume soft foods, cool liquids for comforts. Other comfort measures would including a humidifier in the client's room. Humidified air is more gentle on the airway. It also helps to kind of loosen up some of those secretions, make them easier to expectorate or cough up. Clients can gargle with warm salt water to help reduce that pain. The solution of salt and water also helps a little bit with the inflammation. And we're going to do some really important teaching to keep these clients from getting reinfected. So first, teach the caregiver. Most of these pediatric clients will have a caregiver or a parent that we need to give the majority of the teaching to. They're the one calling the shots. But the client needs to know, the caregiver of the client needs to know that the client will be considered contagious until 24 hours after starting antibiotics. So this is really important when it comes to when they return to school. And we want them to be fever-free for 24 hours as well. So these are our two key little benchmarks we can look at when it comes time to figure out when this child should go back to school. And we also want to tell the caregiver that this pediatric client's toothbrush will need to be discarded about 24 to 48 hours after starting the antibiotics. We don't want any of that residual bacteria to remain on the toothbrush, have the child use it again, and get reinfected. So again, we're discarding that toothbrush about 24 to 48 hours after we initiate antibiotic therapy. Alrighty, so final topic for the day, we're going to talk about head lice. What is a pediatric lecture without a little talk about head lice? The official name for this would be pediculosis capitis. It is, I think, a rite of passage for nurses to get one head lice client, but it's very contagious. Now, RSV we know was a virus, a viral infection. Strep that we covered was a bacterial infection. Now, lice is a contagious parasitic infection, so we have those lice as our parasites. It's spread through contact, and this can be direct or incorrect. So directly, it can be kid to kid, meaning one infected kid spreads it to the other, or indirect, maybe a kid who's infected with lice uses a hairbrush, puts the hairbrush down, another kid picks it up and uses it, now they're infected with lice as well. So what happens with the lice? What's the life cycle here? A female lice will lay an egg. This egg is called a nit on the hair shaft real close to the scalp. Over the course of 2 weeks, these nits develop into adult lice when they hatch. Then those adult lice just continue to lay more eggs, more nits, and this process continues until the lice infection either gets a lot worse or hopefully we treat it. So without treatment, these lice will multiply very quickly. It's one of the things that makes this so contagious. Lice is most commonly seen in school-aged children in childcare facilities where the kids are in really close contact with one another all day, every day. I see someone asked if this live will be posted. It will. All of our lives are posted to our social media afterwards. I think our YouTube channel is the easiest one to search. Go into our search bar and search up whatever topic you want to see, but we do post them afterwards. So clinical features for lice are pretty straightforward. Our biggest one is going to be itching. These kids have severe itching or pruritus. Scratching can also lead to the excoriation of the skin on the scalp, which can be an entryway for subsequent skin infections. So we want to make sure we're really keeping an eye on that. Those nits can be seen a lot of times at the nape of the neck, in the scalp, maybe right behind the ear are the easiest places to spot them. And all they look like are like a light colored little speck in the hair. So pretty much itchy scalp, visible lice are our biggest clinical features of head lice. So our biggest teaching points are going to be in nursing interventions. There are a lot of things we can do to help stamp out this parasitic infection and help prevent it from infecting other people going forward. So in a healthcare facility, before we treat a client with lice, we're going to want to protect ourselves first, cover up before helping the client. Typically, this will be facility specific, but at minimum, you want to have a gown and gloves. In reality, anyone who has hair, especially long hair, is going to want to put a surgical cap on to protect their own hair from lice. Next, we assist the client or instruct them, maybe the client, maybe their caregiver, to apply a pediculicide shampoo, like a 1% permethrin is really common here. We apply that on the scalp, and we need to tell the client or the caregiver to leave this on for 10 minutes, then wash the hair in the sink so they decrease their skin exposure when washing everything out, and wash with warm water. Hot water can lead to vasodilation. We want to decrease that to minimize systemic absorption of this permethrin medicine. Alrighty, after we shampoo, they should run through their hair with an extra fine tooth comb to help remove any residual nits. And most importantly, they need to repeat this 7 to 10 days after the first application to treat any newly hatched lice. The caregiver should also soak any infected hairbrushes in scalding hot water for 10 minutes. Lice travels fast in households, so we need to tell the caregiver to check other members of the family for lice. Be sure someone checks them too. In terms of the household itself, vacuum all carpets, mattresses, and upholstered furniture. We need to wash bedding in hot water and dry it on the hottest setting to absolutely kill those lice. For any item that's non-washable, maybe too big to fit in the washer and dryer, put it in a sealed bag for 2 weeks, which will help to suffocate any residual lice. We also want to keep that pediatric client's nails trimmed really short. Remember we talked about the potential for excoriation of the skin on the scalp from itching. We want to make sure the nails are short so they can't break the skin and cause a secondary infection here. And lastly, with lice, we also want to make sure we're using all of our therapeutic communication techniques. We don't want the client or their caregiver to feel embarrassed or isolated. So we want to make sure we're speaking therapeutically and using our nice communication as nurses. Alrighty, so moving on now, we've finished our lecture material. Let's test our knowledge with some questions. So question 1 is about RSV. So the nurse is caring for an infant with respiratory syncytial virus or RSV. Which of the following findings would the nurse expect to observe? Select all that apply. Our options are fever, tachypnea, poor feeding, sunken fontanelles, and tearless crying. Drop those answers in the chat. Alrighty, let us know what you think. I see someone says, if a child and a dog have lice, which one do we take care of first? Dogs can't get lice, just like people can't get fleas, so we would not be worried about that. Alrighty, great job, you guys. Drop those answers in the chats. Doing phenomenal today. Alrighty, and in the meantime, we are doing some NSNA webinars. So we're partnered with NSNA. We've talked about it a lot, but if you are not familiar, that's the National Student Nurses Association. We have really big presences at the spring and the fall conventions. We were just at the Seattle convention back in April. It was so much fun. Let us know if anyone here joined us. But throughout the year, we're also putting on 6 different virtual webinars. You're able to register via our social media or the NSNA's social media. They'll give you a link. But we just did our second of 6 yesterday on Monday. It went so well. Thank you for anyone that joined. Our next one would be June the 9th, which is also a Monday, and then also Monday, July the 14th. So make sure you guys check that out. Consider joining. It's $25 for NSNA members and $35 for non-members. But we give some really great information about exam strategy and some more information on some of our heavily requested topics like pharmacology, OB, peds, cardiac stuff, just really great information. So visit our social media for links, or you can check out our NSNA partner at their social media to get a link as well. I see Ali on YouTube is an NSNA member. That's so exciting. We're so happy to have you. Consider joining our webinar. We'd love to see you there. I'll look out for you. Alrighty, wonderful. So let's go ahead and jump through our answers here. I see almost all correct options. Way to go, you guys, excuse me. So 1, 2, and 3 was what I was looking for here. Those are our correct options. So why is this fever? We know we can see fever in RSV. One important teaching point here is to give an age-appropriate antipyretic, not aspirin. We're going to give a Tylenol or an acetaminophen. We know we can have that increased rate of breathing or the tachypnea. We can have other signs of labored breathing like those retractions. We can have the nasal flaring as well, and poor feeding will be another symptom of this. If they can't breathe properly, they're not going to be able to eat properly. So 1, 2, and 3 were our correct options. 4 and 5 were incorrect. So why was this? Sunken fontanelles are a sign of dehydration. Now, dehydration can result from RSV, but it's a complication of RSV, not a direct result of it. That's why I wouldn't have chosen number 4. And lastly, tearless crying. This is also an incorrect one. Alrighty, great job, you guys. And someone says we don't give antibiotics in RSV. I think I was talking about antipyretics to bring the fever down. We want to make sure we use an appropriate one, which essentially is just not aspirin, because we talked about that Ray's syndrome risk with our pediatric clients with viral illnesses. So we would give a Tylenol or an acetaminophen. Alrighty. Wonderful. So question number 2. Here we're going to talk about strep. The nurse in the clinic has taught a client with newly diagnosed streptococcal pharyngitis. Which of the following statements by the client would indicate a correct understanding of the teaching? Select all that apply. So is it I should plan to place a humidifier in my bedroom? I should contact the clinic if my urine color changes. I will receive a prescription for an antiviral medication. Drinking cool citrus juices will be soothing to my throat. Gargling with warm salt water mixture may alleviate my pain. Drop those answers in the chat. Let us know what you're thinking. Alrighty, and anyone here, check out uworldnursing.com. We have so many great resources and notably so many free resources that are available to you all. You can look at our question of the day on our social media. We're putting out a question of the week if you want to sign up at uworldnursing.com. We have our lives. We're going live 6 times a week these days. So lots and lots of free resources for you all. You can find out more about all of these at uworldnursing.com. Alrighty. Drop those answers in the chat, and I see lots of correct answers. Way to go, you guys. So I was looking for 1, 2, and 5. So why was this? We're talking about strep, and we're looking for correct understanding of the teaching. So placing that humidifier in the bedroom, that humidified air will help to soothe the throat, and that humidity will add to break up any secretions, make them a little bit looser, a little thinner, and easier to expectorate or to cough up. 2, I should contact the clinic if my urine color changes. Remember, we have a lot of complications that can happen from untreated strep throat. One of them is going to be that acute post-streptococcal glomerulonephritis, and we talked about one of the biggest signs of this, the hallmark signs, is going to be that urine color change, that cola-colored urine. So we should definitely contact the provider if that urine color changes, because this could signify that the client, that strep bacteria has now invaded the kidneys, and this client has acute post-streptococcal glomerulonephritis. Lastly, gargling with warm salt water mixture may alleviate my pain. This is true that warm salt water can reduce pain, help to relieve some of that inflammation, and soothe the throat. So 1, 2, and 5 are going to be our correct options. 3 and 4 were wrong. So why was this? In this case, the 3 talks about an antiviral medication. Remember, strep is bacterial. We would give an antibiotic for a bacterial infection. We give an antiviral for a viral infection. So in this case, we would not give an antiviral. That's incorrect. And lastly, 4, cool citrus juice is going to be acidic. That's going to irritate the throat, not soothe it. So we would not want to give this. Warm salt water mixture would be a better option here. Alrighty. Someone says, please explain option 2. Remember, we talked about acute post-streptococcal glomerulonephritis. That's a potential complication of untreated strep throat. Our biggest sign of this acute post-streptococcal glomerulonephritis is that change in urine color to like a Coca-Cola colored urine. So if we see that, we would need to report it to the provider because this signifies that there's a complication and that they potentially have acute post-streptococcal glomerulonephritis. Great job, you guys. Oh, Abisola says she understands now. Wonderful. Thank you for letting me know. Alrighty, so final question of the day, question number 3. We're going to talk about lice now. So we have a question for each of our topics. The nurse is teaching the parents of school-aged children about the treatment of pediculosis capitis, or head lice. Which of the following information should the nurse include? And another select all that apply. I really challenged you all with a lot of select all that applies today. I didn't mean to do that, but you guys rose to the occasion. So should they wash your child's bed linens in cold water? Should they keep your child's fingernails trimmed short? Remove nits from your child's head using a fine-tooth comb? Treat all your household pets with a pediculicide? Or 5, seal non-washable items in a plastic bag for 10 to 14 days. Drop those answers in the chat. Doing great today. This is our final question of the day. Let us know what you all are thinking. Alrighty, and who here has graduated? Do we have any May graduates? Also let us know who here has passed their NCLEX, who is about to test. I know we're moving in from a big graduation season, kind of early to mid-May, moving into a big testing season in June and July. So I'm sure we have a lot of new graduates, new test takers coming. That's so excited. Rogan on TikTok just graduated. Congratulations. Mira passed already. Oh, overachiever, look at you. That's amazing. Congratulations. Someone else says they graduate in June 5th. And Mean Girl 101 says, hopefully I pass this year. I hope you do too. Best of luck. Alrighty, great job, you guys. Let's go ahead and jump to our correct options. It looks like the majority of you guys got this, and our correct options were 2, 3, and 5. So why was this? 2, keep your fingernails trimmed short. Short fingernails prevent breaking the skin or excoriating it when we scratch it. Remember, we have those potential for subsequent skin infections if we break the skin, which can worsen the infection. So we want to make sure the nails are trimmed short to prevent this. 3, remove nits from your child's head using a fine-tooth comb. Also something we'd want to do. This helps get those nits at the scalp, at the root of the infection for these parasites and prevent a worsening parasitic infection. Lastly, option 5, seal non-washable items in a plastic bag. Great. We want to do this for about 10 days to 2 weeks to suffocate lice on anything that we're not able to wash and dry in our washer and dryer. Alrighty, so 1 and 4 were incorrect. We always want to wash those bed linens in hot water and dry it on the hottest setting to kill off those lice. And lastly, we would not need to treat pets with the pediculicide. Pets cannot get head lice. It requires a human host. Just like humans, while they can get bitten by a flea from a pet, fleas can't live on a human host. So remember, lice is for people and fleas are for pets. So there you go. Alrighty. Someone's asking if we ever do bow tie questions live. We are going to be doing bow tie questions on our NSNA webinars. We just covered case studies. So if you want to see some bow tie questions, join our NSNA webinar. You can see links to this on our social media or NSNA's social media. Thank you guys so much for tuning in. A quick look at our QBank slide. For anyone that already uses our product, here's how to get more questions based on what we spoke about today. And for anyone that hasn't purchased UWorld, here is a quick little look in at all the different ways you can filter our questions if you are considering purchasing. So thanks for joining. I hope to see you guys soon. We're going to be back tomorrow at 11 a.m. Central Standard Time with endocrine questions. Thanks for joining, and I hope to see you guys soon.